Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with lung cancer with Dr. Michael Cohenuram. Dr. Cohenuram is an assistant professor of medicine and medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Mike, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
So I am primarily focused clinically and research-wise on taking care of patients with lung cancer. I did my fellowship at Yale and have stayed in Connecticut ever since. And I am married with 2 adult daughters.
Fantastic. So let's dive into the lung cancer piece of this, since it is Lung Cancer Awareness Month. I think a lot of people know about lung cancer, but maybe you can start off by painting a picture for us. How common is it? How many people die of it? That kind of thing.
Sure. So unfortunately, it is incredibly common. In fact, it is the number one cause of cancer-related deaths, both in the United States and worldwide. There are well over 300,000 new cases of lung cancer a year in the United States, and just shy of 200,000 cancer-related deaths. I think worldwide, the number is well over 5 million. I think probably the biggest myth is that this is purely a smoking-related cancer. Unfortunately, about 1 in every 10 cases of lung cancer occurs in a never smoker. And sometimes we will find secondary causes like secondhand exposure, but oftentimes there's really no known cause at all.
So I want to kind of dive into a couple of things that you mentioned there. So one is that lung cancer remains the number one cancer killer in the U.S. as well as worldwide. I always thought that the incidence rates of smoking were going down. So are we seeing lung cancer incidence rates go down given the fact that 90% of these cancers are smoking related? Or are we just finding that the incidence rates are staying the same because there are other causes of lung cancer that we're now discovering that are taking its place?
That is a great question. Unfortunately, so far, the numbers are not going down. Although what's interesting is they have gone down in men. But interestingly enough, the numbers have increased in women, and this is probably a lag effect. I think women began smoking somewhat later on than when it was a huge fad among men. So we are starting to see the dip in men as smoking rates have gone down, but we haven't yet seen that dip in women. I think otherwise as I said, there are other causes. I'm sure there is a contribution of air pollution. In Connecticut, as well as in several other states, there's an environmental pollutant called radon, which is associated with increased rates of lung cancer. And I project, although certainly this is far from fact, that we'll probably see some kind of increase related to vaping and other forms of smokeless tobacco.
Is there a genetic proponent? I mean, so often when we talk about cancers on this show, there's a lot of these environmental factors, but there's often some genetic factors as well. Do we know anything about the genetics of lung cancer?
Yeah, it's interesting. I have certainly seen familial cases, although in general, they have not yet identified any type of hereditary syndromes the way we see in like breast cancer or ovarian cancer, with genes like CHEK2 and BRCA1 and 2. Part of the question has always come up among those families, is there some other type of common causative agent, whether it's something environmental or, the kids didn't smoke, but the parents smoked. So we just don't know. But at this point, we don't have any known hereditary factor.
And so can we talk a little bit about finding cancer early and preventing it. So we know that probably the number one way to prevent lung cancer is don't smoke. And I suppose avoiding air pollution and radon would be other things to do. Anything else on the primary prevention side that people can do to prevent themselves from getting lung cancer?
I don't think there's any other strategy really to avoid getting it. I mean, there was no doubt that I would say, the approach number 1, 2, and 3 is don't smoke, don't smoke, don't smoke. And I am an incessant nag to my patients trying to get them to not smoke. I think, as you said, really the next most important approach is to catch it early. And I think much like we have done in breast cancer, as well as colon cancer and cervical cancer, there's increasing uptake of screening. And there's really the hope that while the incidence of lung cancer won't go down, we will catch it at far earlier stages with a much greater proportion of those lung cancer cases being at a stage that we can cure.
So before we dive into screening, and I do want to go there, when you say that you're an incessant nag for your patients about not smoking, and I'm right there with you. One of the questions I think is that, smoking is so addictive. Any tips on best strategies? So let's suppose somebody's listening to this show and thinking, yeah, I probably should quit, but how? I mean, do you have any tips on best practices for quitting smoking? Some people had thought about vaping as an alternative to smoking, but when we go back to what you said earlier, vaping might be just as bad, if not worse.
Yeah, so I guess I'll start off with the end point of that question. I don't know that vaping is worse. I just don't. It's certainly not nearly as good as not smoking at all. And I do still think that there is a role that if the only way for you to stop smoking is to substitute it, it is probably better to vape than it is to smoke. I think that being said, there are so many other strategies, from using medication like bupropion to Nicorette gum to patches, hypnosis. I think really the two key things are, one, you truly have to be motivated to stop. I don't know that any strategy works unless you really, really want to stop. And the second thing is there's nothing wrong with getting help. And there are a number of smoking cessation clinics, both at Yale as well as in the community, with different strategies applied for, people who have different triggers for smoking.
Yeah. And I think, even if you go to the CDC website, there are toolkits on there. There's 1-800 numbers you can call to help get help to quit smoking. But I agree with you. I think that if we can really reduce the number of people smoking, we might be able to make a dent in terms of lung cancer. But without that, it's going to be an uphill battle. Let's dive into the screening strategy. So for people who have been long-term smokers, potentially there is screening for lung cancer. Can you walk us through who's eligible for screening, what that entails, how often they should do it, and so on?
So I have to plead a little bit of ignorance. I don't know the specific nuances because I feel like it changes pretty frequently. Yeah. But basically there's something called a pretest probability. So it's not something that's recommended for everybody. It's recommended for people who are genuinely at an increased risk of lung cancer. So they identify people who have smoked a certain amount of years. I believe the target number is somewhere about 20 years. So whether you are half a pack a day for smoker for 40 years, or you smoke 1 pack a day for 20 years, or 2 packs a day for 10 years. And then they also will look at overall health and what the person's life expectancy is. And the imaging modality that they use is a low-dose CAT scan, because there is certainly concern in the community about the potential risks of radiation from the CAT scan itself. And this particular CAT scan uses far less radiation than a more standard CAT scan. And I've heard the number compared that it's actually less radiation than if you flew down to Florida. So I think the potential harm to the patient is low. And I believe the CAT scans are done once every year to 2 years. And they have a rating system actually similar to a mammogram, which uses BI-RADS. In this case, they use lung RADS, where the radiologists have actually determined what are concerning appearing nodules and what are not, and how closely they should be followed, or should they not be of a concern at all. But there's no doubt that we are seeing more early stage disease, which is fantastic.
Yeah. And that's great for people who have got the 20-pack years of smoking and who are either current smokers or who have quit within the last 15 years and are within that 50 to 70 age range. But as you said, 10% of people who get lung cancer aren't smokers, and so they wouldn't be eligible for screening. So talk to us a little bit about some of the kind of the signs and symptoms. What should people who might be non-smokers, or smokers for that matter, what should people be looking for in terms of signs and symptoms of lung cancer so that they can get to their doctor and potentially get evaluated?
Sure. So first of all, let me be clear. Yes, 10% of lung cancers are non-smokers, and it is surprisingly common. I mean, there are actually more non-smoking related lung cancers than patients treated with pancreatic cancer during any given year. But the vast majority of people are not diagnosed with lung cancer. And if you take 10% of that number, it is still a very low number. So I don't want people to drive themselves crazy searching for red flag symptoms. But I think if patients have a persistent cough, certainly if there's any signs of blood in the mucus, if they develop shortness of breath, if they have noticed a progressive loss of appetite or weight, I don't think people should minimize that. Some of it is people just they feel so reassured by the fact that lung cancer is not possible that they don't even entertain this as a possibility. And I think sometimes people are afraid and don't seek help because they're afraid that their worst fears are going to be confirmed. But really at this point, we've made so many advances that I just want patients to know that if there is something, it is almost a guarantee that we can help them.
Yeah. And I think that that's so important. I mean, it's kind of like the old adage that the only thing worse than finding out that you have lung cancer is not finding out and waiting until it's too late. Because as you say, there have been many advances. So we're going to dive into a lot of those advances. But first, we need to take a short break for a medical minute. So please stay tuned to learn more about the care of patients with lung cancer with my guest, Dr. Michael Cohenuram.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. Genetic testing can be useful for people with certain types of cancer that seem to run in their families. Genetic counseling is a process that includes collecting a detailed personal and family history, a risk assessment, and a discussion of genetic testing options. Only about 5 to 10% of all cancers are inherited, and genetic testing is not recommended for everyone. Individuals who have a personal and/or family history that includes cancer at unusually early ages, multiple relatives on the same side of the family with the same cancer, more than one diagnosis of cancer in the same individual, rare cancers, or family history of a known altered cancer predisposing gene could be candidates for genetic testing. Resources for genetic counseling and testing are available at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Michael Cohenuram. We're talking about the care of patients with lung cancer in honor of Lung Cancer Awareness Month. Now, right before the break, we were talking about the fact that lung cancer remains one of the most common malignancies affecting people worldwide, and that the rates have really remained the same despite the fact that we've seen at least a decline in smoking rates among men. Those rates continue to be high amongst women. But Dr. Cohenuram was telling us about lung cancer screening with low-dose CT, which can potentially find cancers early. Now, Mike, one of the things that this leads us to then is, okay, so let's suppose you have a low-dose CT and it finds something suspicious. How is the diagnosis made? And what does treatment look like from there?
So generally it would involve getting some kind of biopsy. And a biopsy would be taking a bit of the tumor or whatever the nodule is. Obviously, hopefully, whoever is getting that CAT scan, the nodule is not involved by cancer, and it just caused a lot of anxiety, and we can have a collective whew. But in the case that it is cancer, then generally we would have a patient see both a thoracic surgeon as well as a radiation oncologist. Surgery for lung cancer has changed dramatically. I think as it has for a number of different things. I think, people always imagine ribs being cracked and that it's a very painful surgery, but they, much like orthopedic surgery or anything else, it's done minimally invasively now. In fact, I think at Yale, many of the surgeons are doing it robotically, and I've seen patients 1 week after their surgery not even taking Tylenol. And the incisions are oftentimes no wider than a fingernail. If a patient cannot undergo surgery because of a number of other, say they have bad emphysema or heart disease, or if they simply just do not want to undergo surgery, then they can undergo a very focused kind of radiation called stereotactic radiosurgery, which is generally done in 3 to 4 treatments over the space of a week to a week and a half. And for that, we would have them see a radiation oncologist. They'll sometimes need some additional testing, whether it's a PET scan to look at their whole body. Sometimes we'll do an MRI of the brain because there is an increased incidence of lung cancer going to the brain. And depending on what the initial CAT scan looked like and whether it was a somewhat higher risk looking scan, they may have to undergo a procedure called an endobronchial ultrasound to sample lymph nodes.
In your discussion, it sounds like this is really localized therapy, either surgery, which PS sounds incredibly good compared to what many people might be thinking of thoracic surgery, or radiation. Where does systemic therapy fit into this?
So systemic therapy in general is given if either A, we find that after the surgery, the stage, which is either the size of the cancer and or whether lymph nodes are involved, if we find that that patient is at a high enough risk of the cancer coming back at some point in the future, or if the cancer itself is most likely curable, but we need to shrink it first to help the surgeon. And then so if there are high-risk features at the time of surgery, then we'll offer something called adjuvant therapy, which is to wipe out the little cancer seedlings that could lead to the return of the cancer at some point in the future. Or we can offer systemic therapy before surgery, what we call neoadjuvant therapy, to shrink the cancer. And with the preoperative therapy, which we give in combination with immune therapy, that can actually result in complete eradication of the cancer in close to 1 out of every 3 patients.
So how do we know what are these high-risk features? So somebody who might be listening to this show may be saying, okay, so if I'm discovered to have lung cancer, what are the features that I should be looking at that might mean that I might need some sort of chemotherapy or other systemic therapy?
First of all, they don't really have to look out for anything. Hopefully they have a good relationship with a surgeon and they've met with a medical oncologist, and we can very much share with them the things that we may or may not be concerned about and why we're doing what we're doing. But really, again, the main things that we look at are the size of the cancer. Obviously, the bigger the cancer, the more concerning it is, and also whether lymph nodes are involved. And certainly once lymph nodes are involved, much as we see in almost every other form of cancer, that significantly increases the likelihood that the cancer may have already spread beyond the lung, and that simply doing surgery alone is not enough to truly cure the person.
And so if they have lymph node spread, but even if they don't, if the cancer is invasive and it has the ability to spread, what kind of things can a patient expect in order to minimize the chances of recurrence?
Okay. So, Anise, to decrease the risk of cancer recurrence, we really use a number of different therapies. The standard is chemotherapy, which can provide a significant reduction in the risk of the cancer coming back. But we now also have literature supporting the benefits of targeted therapy if patients have certain genetic profiles. And we now also routinely use immune therapy in those patients whose tumors indicate that they stand to benefit from immune therapy. So we're really using one, if not several, different tools in our tool belts to help patients increase their chances of being cured.
So, Mike, it really sounds like a lot of this has to do with personalized medicine, the idea of looking for these mutations, looking for PD-L1. Is that something that every lung cancer patient should now expect when they get treated for lung cancer, that their tumor is going to be checked for all of these markers, and that these personalized therapies are covered by insurance?
So out in the community where the cost may be a little more burdensome, I don't know that they have to do the full genetic sequencing that we can do at an academic center like Yale, but they should at least be checking for the mutations for which there are drugs that have clear evidence that they can help people in earlier stage disease. And specifically right now, that would be EGFR and ALK. And both of these are mutations that we primarily see in non-smokers, although sometimes we'll see in people who have a smoking history. I think the advantage of doing all of the genetic testing is that if, God forbid, the cancer does recur in the future, that you have all of that information and you can hit the ground running and being able to help the patient without the wait time of getting those results. Because a lot of these targeted therapies are not only far better tolerated than traditional chemotherapy, they're actually far, far more effective.
So just a couple of questions to follow up on that. If somebody were to get a recurrence, is it a guarantee that it will have the same genetic profile as the original, or could it change? I mean, would they not need to repeat all of those studies, or would it be actually advantageous to repeat them in case the phenotype of that cancer changed and they could treat with a different regimen?
So generally in cancers, the genetic abnormalities don't change unless you have had treatment directly targeting that gene. And it's like any form of evolution. You're not going to lose that abnormality unless there's a pressure on the cells to lose that abnormality. So, for instance, if a patient has an EGFR mutation and they received postoperative drugs targeting that mutation, which would be a drug called osimertinib, certainly, if the cancer recurred after treatment with osimertinib, we would rebiopsy it to see either A, if it has a new mutation or has acquired a second mutation that allowed it to detour around that. But in general, if a patient hasn't received targeted therapy, those mutations really stay the same.
And so would you say that the majority of people, though, if they have a lung cancer and the genetic profile has been done and they have either an ALK mutation or whatever, that they would be treated with a targeted agent? Or is that really only if they are lymph node positive, for example? And if they're lymph node negative, even if they have that mutation, they may not be treated.
You are full of good questions. So there was a study in patients with EGFR called the ADORA study, conducted through Dr. Roy Herbst, who's here at Yale. And they found that postoperative osimertinib, this oral targeted therapy, worked significantly even in patients with stage 1 disease, although the benefit was smaller than it was in patients with higher stage disease. They've just recently released a press release on postoperative alectinib, and I haven't seen the details of that study in terms of whether it included early stage patients would be patients with no lymph node involvement. But I think in general, it's something that we offer patients, but I don't push it as strongly if they don't have nodal involvement.
Mm-hmm. And so, looking to the future, one can imagine that might be an area of investigation to see whether, in fact, these really early stage patients may benefit from these targeted agents. What else is on the horizon that excites you?
Probably the most exciting thing is just the newest advances in immune therapy. Immune therapy really has changed the treatment of lung cancer. I mean, when I went into oncology just about 20 years ago, the 5-year survival rate was 3%, and now it's over 30%. And I think much of that is due to the use of immune therapy. For those patients who benefit from immune therapy, the benefits are dramatic, but unfortunately, far too few patients benefit. And what they're looking into is other ways in which they can engage the immune system, other treatments that they can combine with standard immune therapy. So I think that's really the most exciting thing. The other thing is they're looking into a form of treatment called ADCCs, which is a combination of an antibody bound to a chemotherapy. Which I think is a really exciting way of delivering chemotherapy directly into the cancer cell, with the hopes that there's minimal chemotherapy delivered to the healthy parts of the body. So you get improved efficacy, but fewer side effects.
Yeah. In terms of the systemic therapy, we know that surgery is short-lived. It's kind of one operation usually. Radiation, it tends to be fairly short, maybe a few weeks. How long is systemic therapy? I mean, we see in different kinds of cancers that chemotherapy could be, 4 months. Endocrine therapy for breast cancer can be 5 and maybe even 10 years. What's it like for lung cancer?
That's a great question. So generally, if it's given after surgery, it's about a 3-month period of chemotherapy. And then if a patient's eligible for immune therapy, we do that for a period of 1 year, almost similar to the way we give Herceptin after breast cancer treatment. Oftentimes, though, if a patient has stage 4 incurable cancer, you're treating them as long as they're tolerating it and as long as it's working. So that the longer, the better. And you could be talking about several years.
Dr. Michael Cohenuram is an assistant professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.